Irina. It's nice to see you again.
Welcome, Chuck. Thank you so much for having me.
You're very welcome. Why don't you tell us, to start out, why don't you tell us a little bit about your background and what you're doing now?
Sure. So I'm a periodontist, and I am trying to divide my time between private practice and also teaching. In private practice, I also like to include practice-based research. So kind of like a little bit of my own patients, but then also integrating some of the new concepts and trying to advance the field of oral regeneration. In terms of teaching, I'm very lucky to exchange ideas with colleagues at Tufts and Harvard in Boston. And just being there, trying to take good care of patients.
Well, that's good, and molding the future of
working
periodontics,
on it,
right?
working on it.
One student at a time.
What about you?
So that's good. Yeah, my background's it's kind of varied. General dentistry. I graduated from dental school and ended up doing a couple of general practice residencies, and then went into private practice. And about halfway through my career, I took a little left-hand turn and worked for an implant manufacturing company. And then went back into private practice again, and coming up on year 30 right now in dentistry. So it's amazing that it's gone by that quickly. And right now,
You're very young for 30 years of practice. Okay,
I feel old sometimes with it, and I'm at the end of my clinical side of things with wet finger dentistry, and as of January of this year, I came on as the VP of Clinical Development at Implant, working with Osteogen and the Osteogen product line. So I'm really excited about this new avenue. I get to work with people like you, and it's fantastic.
Super. We're glad to have you. So I think that really speaks highly in terms of the direction of the company and the fact that they are investing in such a role to be able to support the advancement of the field.
I appreciate that. Thank you so much.
So Chuck, day to day, you were talking about kind of like blending between private practice and then your role with Implant. You get to live the practical realities of grafting day after day, right? In terms of like, how would you describe your clinical perspective and the problems you are trying to resolve for your patients, right? As a general dentist, I think you see a variety of different patients.
Yeah, absolutely, and we see patients in varying states, just as probably you do too. My goal is to first and foremost try to prevent future problems. That's what I would like to do. Prevent future problems, address current problems. From a grafting point of view, this is something that it really fits into that thought process, especially with the amount of teeth that have a tendency to come out, at least that I see in my own practice. My practice is really kind of shifted towards the geriatric side. And so we see a lot of failing dentistry, and that failing dentistry results many times in extractions. And what I like to do is I like to address that by preventing further problems, by preserving the ridge. That's my number one goal. What I also want to do is I want to try to do it affordably for my patients, because it's very difficult sometimes for, especially patients that are on fixed incomes, for them to have the proper treatment. You'd like to give them the Cadillac treatment that's out there, but many times you may have to make compromises. And I feel that we don't have to make those compromises. I feel that there's a way to treat these patients at a very good, not only price point, but in an expedient way that we can move on to the next phase of their treatment, whether that be conventional fixed or removable or implants. So grafting kind of involves all of that for me.
And I know that you've been doing this for over 13 years now, and I know we had various conversations about your experiences over time. So what was actually your decision-making process? Like, why did you decide to integrate this into your practice at the beginning?
So with Osteogen, it was looking for a product that was going to solve the inadequacies that I was seeing with my conventional grafting materials that I had learned in school and learned in residency. In my residency program, we were very bovine based with our grafting materials. And when I got into doing implant therapy, two of the problems that would come up was one, that I had to wait greater than 6 months usually in order to come back and to place an implant. And then many times when I did come back in on re-entry, I ended up finding grafting granules that were not turned over, granules that were encapsulated with connective tissue. And it was a problem that I wasn't sure how to solve. I moved from there to allograft materials, and that helped tremendously from what I was seeing in bovine-based graft materials. But I then wanted to try to find something that I knew was going to be not only predictable, but was also going to be easy for me to use, and that I could do treatment affordably and very quickly. And part of that was due to the fact that many times in private practice, in the general practice side of things, we're jumping from chair to chair to chair, and that puts time constraints on our treatment. We don't want to provide treatment that is not up to the level that we want, but what we want is products that are going to accomplish things that are on par with other products or better at a faster rate, either a faster rate of being able to do the actual procedure or a faster rate of being able to come back and do a secondary procedure.
Great.
Yeah. So, I mean, that's the reasons that I kind of jumped into things, and I was looking for a better mousetrap, basically. With your background, I mean, what in your mind is the ideal grafting material? If you were to just explain it to your grandmother or your father who doesn't have a dental background, what would be the way that you would express what you really want out of a material?
I think for me, will be something that I know it will lead to true regeneration. Because I think as a specialist, a lot of the patients that come to us, they come because they know that either they had an unfortunate experience or they had a complication, or whether, they have different expectations in terms of, some of the biomaterials that we're using are a little bit more diverse compared to some of the, local general dentists that they just have access to one or two. They know that when they come to us, we have a variety. And I mean by that we can also tailor based on their religious consideration, based on their all these other preferences that they might have. So I think it's kind of like a balance between making sure that we can achieve true regeneration and will serve very well as a future site development for a future implant. Okay. Right. And then from there, I think we also have to marry that to who is our patient, because, we see all these diverse patients. And especially, apart from my office, which I'm very happy you came to visit today.
Yeah. Oh, beautiful office.
Thank you, in downtown Boston. I also teach at the university, right? So, some of those patients, they do have financial limitations. So I feel like it's almost, I have to look at it as a trifecta, has to achieve oral regeneration, has to meet the expectations of the patient, but also cost is important because not everybody is able to afford the fee-for-service practice.
Right.
So I have to kind of like look at all of those things. So I think for me that's very important at this point. And when you're looking at, the ideal bone graft, of course, when you're looking at apart from achieving oral regeneration and all of those things, you can't spend too much time. So it has to be pretty easy to use.
Right.
In the clinical setting. It has to be easy for my students as well and for my residents, because some of them, they take like 2 hours to complete an extraction. So it's kind of like 11:30. The session finishes at 12.
Right.
So sometimes they don't have enough time to, put the bone graft and the membrane. So, it has to be something that is easy to handle for them. And then for me, I look at more like chair time valuation, right? And it's kind of like, okay, how much time does it take me to do this? And so I think there are a couple of factors that we have to be mindful of. And I feel like as our field is evolving, I think we're looking much more beyond just like the clinical result and the x-ray. We have to look at other things as well, right? We talked about the patient and then also the practice management aspect.
Right. Yeah. Oh, absolutely. And I think it's, we can never forget that we're in a healthcare business. and you do have to be mindful of those aspects. So that's I agree with you 100% on that.
Super.
Yeah.
So when we're thinking about, the conversation with the extraction and ridge preservation, right? Do you do that grafting after every extraction, or how do you actually decide when are you going to graft? And
It's a good question. I mean, in an ideal world, I always treatment plan for an extraction along with alveolar ridge preservation. So that's something that's automatic, that we say that is. Now, whether the patient is going to accept that treatment or not, that becomes a different conversation, which relies a lot upon education of what we're trying to accomplish. I feel that you should do it to alleviate potential problems, whether they be loss of volume of bone that is going to then make secondary treatment, prosthetic treatment, more difficult, or that it's going to contribute to periodontal problems with adjacent teeth. And so that's kind of how we address it with the patients, to get them informed of what the ramifications are if they don't do treatment. What I also like to let them know is that we are trying to open up a window of opportunity for them. And that window of opportunity is not forever. And we explain that to them. We say, even if we do graft today and you wait 10, 15 years to do anything, the chances are you're going to have resorption of that bone at some point. But we're going to end up in a better situation than we could be if we didn't do anything at all. The only times that we don't really do it is in situations of large infections. And so that would be if I have a patient that comes in, has a large chronic infection that there's suppuration, we're not going to graft at that point. We're going to get things, clean everything out, and then usually what we're going to do is we're going to wait, maybe do a delayed grafting if we need to, or we might end up at that point letting them heal and coming back and seeing what it is. But those are kind of unique situations. Most of the time we can get to a point that we can graft at the time of extraction, and that's my preference. Absolutely, it should. There was talk all the way back in 2012 with Gordon Christensen talking about that it should be standard of care. It hasn't got to that point yet, which really amazes me, but we're pretty darn close. And I feel in my practice it is how I am going to treatment plan every patient that's going to lose a tooth. They're going to get some sort of replacement graft. Yeah. So you being on the specialist side, many times you see the results of what comes from your referring dentists. And I'm the first one to admit that not every grafting case comes out exactly as we would like. How do you handle things when they come to you and maybe grafting was not done well, or maybe there was no grafting done at all? How does that look clinically to you, and what does that change the way that you proceed with that patient's treatment from then out? I know it's a long question, but basically what happens when somebody comes in and things didn't go well?
Yeah. So I think number one, you have to understand whether they did bone graft or not, right? Because I feel like if there was no bone graft done, we know that, it's just like naturally, especially if your socket, the walls were very thin, it's just going to collapse and it's going to resorb. But if bone graft was done, and I always try to kind of like communicate that with the general dentist, I try to ask them, what type of material did you use? And, how did that process, did you have any complication? Because I don't want to be in the situation of telling the patient, I'm sorry, you already paid for the bone graft, but we need to do another bone graft again. So I feel like I'm always very mindful of that.
Sure.
So when I see something, I just pick up the phone and I just call my colleague, because I'm very grateful. I'm a B2B business. Like if I didn't have any referrals, I wouldn't have any patients. So I feel like I need to be very respectful of my referrals. So if that's the case, let's say, we can go scenario number one, we didn't do the bone graft, right? Then I just explain to the patient, when Dr. Chuck extracted the tooth, I think there was a conversation there, and most probably you both agreed that we shouldn't do bone graft. So, you didn't know for sure whether you wanted to have an implant or not, and it looks like now you changed your mind. Don't worry, we have a solution for you. If the bone graft was done, then I'm really trying to understand why did it resorb, what type of material they used, is the patient having any medical condition, any osteoporosis, anything that diabetes that might have impacted that, okay? And if none of that is kind of like valid, the next one on my decision making tree really goes back to, I'm gonna try to place the implant and bone graft at the same time. So that's kind of like the conversation that I have with the patient.
Right.
Very rarely I tell them that you had the bone graft done by Dr. Chuck and now I have to do it again because he didn't do a good job. Like, this never happens. So I always try, I understand that I want to be mindful of the fact that you already invested in the bone graft. And, you know, this technology is great because oftentimes we look at the cone beam CT, right? And we have the implant planning. We try to kind of like digitally plan the implant. And, you know, it looks like I can place like a regular platform there, okay? And then we can just do some bone graft at the same time. But if I really open it up and I see the ridges like really, really thin, then I just tell them, you know, if you were my mom, my dad, my sister, my brother, like, I just wouldn't do this. And, you know, kind of like I refer back to the fact that this is the foundation of the house. You don't want to place an implant, you know, in somewhere that is not really strong. So let's take a step back, okay? Let's rebuild this, and then we're gonna go back and we're gonna place the implant. I'm also very mindful of my referral, so I usually like to eat that cost of the GBR.
Okay.
So the way I approach it is, because the patient already paid for the ridge preservation, most probably at that time, I will never charge them like the full price of a GBR with bone. I just can't. I just can't. It's almost like, you know, if sometimes I see patients that come to me because they had a implant that failed, right? And they come for the second time around. I always give them like a 20% discount, just because like the chances of your second implant to be successful, 80%. So I don't know. It's just kind of like, is my practice philosophy in a way. And I just feel like I just need to do that for you. And as a practice owner, I can do that. And I feel like they really appreciate, even if it's a little bit there, I feel like they really appreciate it.
Yeah, no, so, that's great. I mean, I've never really seen that from a lot of the specialists that I've referred to over the years. And
Bring them
you know,
to Boston.
if it wasn't right, if I didn't have to send my patients cross country to you, but no, I think that's a fantastic way to look at it, because it's doing what's best for the patient, right? And we know that things don't always work out, and it's not necessarily anybody's fault that it doesn't work out. And it's really horrible when the patient takes the brunt for it, you know, and it is. And sometimes, you know, some of this treatment, because it is expensive, it can really make or break. So that is, you know, you kind of got taken aback a little bit by that, but it speaks volumes for you, and I love that. Before we move on to anything else, do you take into account the reason that the tooth was lost in the first place? Meaning, what was it? Was it an endodontic failure? Was it a periodontal issue that caused it, or was it a fracture? Does that ever change the way that you look at things with regard to how you're going to address it grafting wise?
Yes, for sure. So, and also like the medical history and the age and all of that. So I think, you know, I had patients that were referred to me for implant placement, but they still had active periodontal disease. It's like, you know,
yeah, you got to clean house first.
I just cannot do that. And I'm sure there are like 1,000 periodontists in the New England area that will do that. I just cannot. So sometimes kind of like you have to take a step back. If they failed for, you know, like root fracture or like an endodontic failure, you know, that's a little bit of a different story. But if they had periodontal disease, we really want to manage that first before we go into the next step. And sometimes it's hard also in the conversation with the referrer, right? Because I think they refer this patient to you for the implant and they expect that this patient is going to go back to them in like 4 to 6 months. And here I am, well, I think I should do another round of scaling and root planning, and I think we should keep you on maintenance a little bit, and then we can move on and place the implant. but it is the way we practice, and I always tell them, and they understand. Like I never, I mean, I feel like we're very fortunate that, you know, we live surrounded by the majority of clinicians that really want what's best for their patients. So I'm not really concerned about that. And sometimes they're like, I'm so glad you pointed that out to the patient, because I've been trying to tell them that they have active periodontal disease and they just don't want to listen. But all of a sudden, when you told them, it just clicked, and they're kind of like very motivated now. And so I hope that answered the
Yeah, no, absolutely. Yeah, I appreciate that. Thank you.
Super. So as we kind of like try to go back to best practices, right? And you mentioned earlier almost 15 years of experience. So tell us kind of like, what is your protocol when you're using the osteogen plug for an extraction? Just walk me through step by step, please.
So, you know, as with any extraction, what we want to do is we want to minimize the damage to both hard and soft tissue. So atraumatic extraction is the goal of get that tooth out with the least amount of inflammation and the least amount of damage to adjacent structures. Sometimes that's not possible, but that's what our goal is. And then once we've gotten that tooth out, then it really is important to start with a clean site. And that really is aggressively going in, either curetting with curettes, sharp curettes, or going in with a degranulation burr, which is a product that I rely on a lot. It's so nice to be able to just run those up and down within the site and get out any of the junk that's in there. And then we need to get bleeding. And so, you know, with any graft, as you know, it needs to have a blood supply. With the osteogen plug composite graft, it's imperative that we have a good blood supply, because that is really going to kick off the new healing and regeneration process. So we get a profusely bleeding site. If I'm still not able to get it through serrated curettes and degranulation burrs, then I'll pick up a surgical handpiece with maybe a long shank 557 on it, and I'll punch some small holes through the lamina dura. Get it. What I consider good bleeding is my assistant goes down, suctions the socket dry, and within 15-20 seconds that thing's filled right back up.
I see.
At that point, then what I can do is I can come in then with my osteogen plug. That plug is delivered dry. It's slowly compressed down into the site. As it's compressed down and the blood soaks into it, it's going to conform to the anatomy that's there. Get it down. Doesn't have to be below the height of the crest. It just basically just slightly below soft tissue level, and then suture it with a figure 8 suture, and then usually a single interrupted over the top of it to keep that plug from being able to move. By compressing it down, and what you're doing is you're kind of activating what we call the bioactivity, which is it's creating an environment where fibroblasts want to creep across it relatively rapidly without being able to dive down into it. So there is no need for an additional membrane in most cases. What I like to say is, as long as I have 4 walls, I'm not going to use a membrane. If I have a large dehiscence or I have a large portion of a wall missing, then I will usually come in with a membrane also, more of a belt and suspenders approach. I know lots of practitioners that don't necessarily use a membrane and still get really great results. And then what we basically do is it's just, after that, it's normal post-op instructions to the patient. One of the things that we do add to our post-op instructions is, because this has got a relatively high collagen content to it, I want my patients to, in these days, to stay away from energy drinks and pre-workout drinks and sodas, things like that, because those will affect the speed at which collagen can be broken down, and we want that clot and the collagen to stay intact. And then what to expect, I tell the patients that your discomfort is going to be minimized by the fact that we have grafted, because we're creating a great environment for a clot to start. Again, we give them all the regular post-op instructions. We see them back at about 2.5 weeks to remove the sutures on it, and then we expect between 3 to 5 months for healing on that. And so we let them know that we know that this material is going to be radiolucent when we place it, and we're going to bring them back in 3 months we're going to take a check x-ray at that post-op appointment, look to see what the bone looks like. If it's become more radio opaque, then we'll usually then go to a cone beam to just see what the volume really is, and then we can move on to their next treatment. So yeah, I like to inform the patients of what their road is ahead of them, because then there's no questions, or there usually is questions, but at least you've told them once, and we can go from there.
Perfect. And I'm sure you tried a lot of products over the years, right? What kind of like made you use more Osteogen plug instead of something else?
Just some of the things that I already touched upon. One, the time of turnover with some of these materials, migration of graft material. If you think about a standard socket preservation using a particulate, you're going to then need something else to contain that particulate. Back, 25 years ago, we were taught you put a collagen plug on top and then suture that in place. The unfortunate part about that is the collagen plug had a tendency to resorb really quickly or be lost, and then you have particulate that can come free. So I was looking for something that, at least initially, that could solve these problems and make my treatment more efficient for the patients. I also use in the example of alveolar ridge preservation or socket preservation. For me, it's not something that I'm looking. I charge a very nominal fee for it, because for me it has two advantages. One, it's going to give the patient the advantage of making sure that we have bone to work with in 3 to 5 months, and it's kind of self-serving also in the fact that it makes my secondary procedure or my implant placement much easier when I know I've got bone volume there. And what has happened is over the years, I've developed other uses for these products, and it really has become my go-to grafting material for many of the things that I use. And I find that it's a better alternative than a particulate or a paste that's out there, whether it's xenograft or allograft or even other alloplasts.
Super. And, I think there is a phrase that people are talking about all the time, that, bioactive crystal technology, and how Osteogen is very well known for that. For somebody that maybe is now interested to learn more about the technology, can you share a couple of ideas? What is that?
Sure. No, that's a great question. Bioactive crystal technology really is the basis for this. And so when we talk about it, there's both a physical aspect to bioactive crystal technology, and then there is the effect on biology. Okay, so we kind of touched on the physical effect. The combination of crystals and the collagen matrix of the plug create a barrier for our soft tissue. So we know that we're going to get soft tissue closure relatively quickly. On a more biologic level, what it is doing is the makeup of the crystal, which is a calcium phosphate, which is a grown crystal. And this grown crystal is low density and highly porous. A big key factor is that it's not sintered, meaning it's not produced under a high temperature, which has a tendency to create ceramics. And we can get into that at another time. What ends up happening is that this crystal is formed, and this crystal is able to provide calcium, phosphate, and hydroxyl groups to the bony environment in the extraction site or the grafted area. The calcium is necessary in order to convert our osteoblasts into osteocytes. The phosphate is necessary for recruitment of cells into the area. And then the hydroxyl groups are really important because those are what are going to allow this molecule to interact. Okay. And it does some other things too, because what it does is it changes the environment. It changes it to more of an alkaline environment, which is conducive for new bone growth and for mineralization. And what we see is that these bioactive crystals, which are also biomimetic, meaning that they mimic bone, that on histology, we're seeing bone and crystal becoming one. And then these crystals over a period of time of 3 to 5 months resorb away, being replaced by natural bone. So by using something like this, what we're doing is we're affecting and changing the local environment to be the most conducive, best environment for regeneration.
Super.
Yeah.
Super. Thank you. So when we think about, and you mentioned this so many times that, when you're using the osteogen plug, we don't really need a membrane. And I got to that decision a little bit later in life, but at the beginning I tried to use the plug and I was doing the membrane. I don't know why, but that's kind of like how I was trained. We put the bone graft, we put the membrane, that's true regeneration. But I know you talked about the fact that, you never use a membrane these days, unless, especially if you have like a 4-wall, unless you have like a dehiscence there that is pretty large. So why is that? Like, how did you get to that decision-making process?
I mean, initially, it was a leap of faith, right?
Oh, yes.
It was a leap of faith at first, and it was counterintuitive to everything I had learned, right? And then I started to look back on what was the reason that a membrane or barrier was necessary. For the most part, the barrier or membrane was necessary to contain the graft material that we were using, right? Being some sort of particulate. Excuse me. Once I realized that wasn't really an issue, then it was a matter of looking at the science to see why this would work the way that it does, and it made sense to me because you put in a collagen membrane and fibroblasts will creep across the top of it. So if you have collagen, a dense collagen with a crystalline matrix in it, and why wouldn't it creep across that also? And so you're right. In my situation, in my clinical experience, that if I've got intact walls, I'm not worrying at all about it. When I'm doing immediate placement and I'm packing osteogen strips in the area, in the gaps around the implant, I'm usually putting a healing abutment on and then drawing the soft tissue up to the healing abutment. And even if I have a small gap, I'm not really worrying about it because in my mind, I basically have a socket that has a titanium screw in the center of it. And that's kind of how I look at it. And I may have simplified it in my head, and that's why it does work. I've always liked to push the boundaries of materials, and this was one of those things where I did take a leap of faith, and thankfully it worked out, and it provided exactly what I thought it was going to do.
Super.
So, I've mentioned, and I've kind of probably thrown around the term regeneration here a couple times. As a periodontist, what is the difference between regeneration and repair, and why do we have to really worry about that?
I think, for us, when we look at those concepts, we're really looking around teeth. So that's kind of like how they were initially described if you go back to the literature. So for us, like real, true regeneration was that you're regenerating bone, you're regenerating cementum, PDL, and soft tissue, right? So you have all of those 4 things that you were trying to regenerate. Oftentimes it happens that if you don't add a membrane, at least in the early stages, then you will have the epithelial cells kind of like go back to the tooth there, and then you will just don't have that bone. So that will be kind of like more of the repair type of concept, long junctional epithelium. I think, when we're looking at some of those clinical cases where I actually used the osteogen plug around an infrabony defect, I'm not able to take a histology to actually see, but what I can see on the radiograph, I can see the periodontal ligament. I can see that it's there. And if my program director was here, he practiced at a time that implant dentistry didn't exist. Like when he retired, he was 85 years old. Like, he just, that's the type of perio he was in the war. That's the type of world that he had to go through, right? And he would always, he was fascinated about these cases. Like, he was like, Irina, let's look at this x-ray. It's been 6 months. Can you see the PDL? Is it straight? Like, is it following the tooth? That's regeneration. We cannot take a core, but I can tell you, once you see that PDL forming, that's really good. And as we shift gears a little bit, as a general dentist, and when you're thinking about regeneration and repair, do you get so excited as Dr. Hawley when you see that PDL? Or not really?
I'm when I'm looking at it, and I'm probably not looking at the PDL as intently as your mentor and instructor did. I look at regeneration or repair. I look at it more in the site where I'm going to eventually want to place an implant. And what I want regeneration. I want the natural bony architecture to exist. What I have found and what the literature has backed up is that on many of the products that are out there, especially these, what I mentioned, the sintered products, these sintered products being dense ceramic, and that can be either HA based or calcium phosphate based, or it can be xenografts that need to be calcined or sintered in order to decrease the pyrogenicity of the product. What happens is it's very difficult for the body to break down. And therefore, you end up getting many times encapsulation. And that's kind of what, at the very beginning of the conversation, I would go back in, I'd open things up, and I'd see the same big chunks that I put in there 6 months before, but there's stuff around it holding it all together. And for me, as a general practitioner that places implants, that's a no-go, right? Drilling through that, it kind of feels like bone, kind of doesn't feel like bone. But my big worry is down the line. What's going to happen once that implant is loaded? And what I have found, at least in my career, looking back at it kind of from a 30,000 foot level and trying to evaluate things that have failed, especially those failures that make no sense at all, right? You place an implant, you do a textbook surgery, everything goes just fine, you restore it, you've got a perfect restoration, everything looks good, and then the patient comes back in 6 months and they're like, it hurts a little bit when I bite. And you take an x-ray and you go, wow, what happened there? Right? And I never really, it was kind of one of those things that we threw in a big pile of, I don't know why this happened, right? You look, first thing you do, you check, okay, has our hygiene been good? Well, yeah, hygiene's been fine. Is the occlusion still what you want it? Yeah, the occlusion's fine. It actually doesn't even make contact, right? And then you go, well, why would this fail? Well, I started to think about that there's difference in bone. And it's that difference between repair and regeneration. And repair looks like bone. It appears to be bone. It will hold an implant like bone. But true regeneration is necessary for long-term health. And I think that's the difference. And that's the way I kind of look at it. It's more about the hard tissue that gets grown back. I personally don't do a lot of grafting against natural teeth. So periodontal types of grafting. I let someone like you that has way more experience than me to do it, and so I'm looking at it from a little different. So yeah, to answer your question, regenerated bone is better bone short and long term for me.
And I want to go back before we go to the next question. When you're looking at that regeneration, and what my program director was telling me, like, Irina, you can see the PDL. What do you see in an extraction socket that you use the osteogen plug from the initial day to like the 4 to 6 months? Are there any changes radiographically that you can see that can lead you to that conclusion that yes, this is the good outcome?
Yeah, no, absolutely.
Tell us more about that.
Okay, yeah. That's one of the things that really makes this a great product from a diagnostic view and for a progression of treatment. When it's put in, it's relatively radiolucent. Now, you still can see that it's there, but it's definitely a very radiolucent. You still see the outline of the socket. It looks like you haven't really done much. And then over time, as the graft material gets resorbed, new bone is formed, we see an increase in radio opacity. And what I'm looking for that point at which I'm seeing the same radio opacity outside of the socket and inside of the socket. And hopefully I'm seeing a dissolution of the lamina dura. I would like that. Though we know sometimes that doesn't happen, it sticks around. And so that to me is a great aspect of this product, because when using something that is very radio opaque, when you put it in, for example, like a xenograft, it's always radio opaque.
Yeah.
And even when it gets turned over, it's still radio opaque, and it's very, very difficult to tell where you are in that healing cycle. What I want to do is I want to be able to say, I'm grafting today, I'm bringing you back in X number of months, we're going to check it, and if it's still radiolucent at that time, we're going to give you another month or two to heal, because not everybody is going to heal at that first 3-month point, right? Depending upon medical history or the size of the defect, those all can affect how long it takes to turn over. But it is a great way to visually check at that point. And we tell the patients, we're like, when we bring you back, we're going to take an X-ray. We're going to see if things look the same here. Look how it looks like on the X-ray here, where it looks like you have a hole here. We're not going to have that hole later. When we get to that point, now it's going to be time for us to be able to place an implant. Yeah. So yeah, I mean, I'm going to flip it to your side. When you look at what the Osteogen product line is, do you, between plugs and strips and blocks, where do you see the most use? What are you using the most within your own practice? At this point, are there products that in this line that you are going to want to kind of experiment with to see if it works? So, what are your thoughts on it?
Yeah, usually my philosophy is like I try to kind of like go for the more predictable therapeutic indication to a little bit more advanced.
Okay.
So I think, I started to use the plugs from sockets that I would never go back and place an implant just to see how the soft tissue was healing. Then I would go to like sockets that were very predictable, like 4 walls. Then I would go to sockets that were like thinner walls. Then going around the GTR kind of like sites, combined defects, peri-implantitis defects, extracting out of an implant and grafting. But I think out of all of those for the plug, by far my favorite is the internal sinus lift. And I do love saving teeth. Trust me, I do love saving teeth. But I feel like, when I have to place an implant and, I need to do simultaneous internal sinus lift, I think the plug, in my opinion, works the best. Just because sometimes when I'm just using like, whether it is like a little block or whether there are granules, I'm always concerned that I'm going to tear the membrane.
Right.
And it might not be like a large membrane that, in the literature says that, you have to place a membrane. Even if there are those micro tears, and, there are some studies that show that depend on the size of the granules, you can have those micro perforations. I just feel very comfortable when I use the plug to actually do the internal sinus lift. So I would say, that's kind of like how far as I've experimented with the plug so far. So far, so good. I recently used a strip for guided tissue regeneration, which was like a very well-contained, kind of like circumferential, pretty good. And I'm very excited to see those positive radiographic changes.
Yeah.
I don't see yet the PDL, but it's a little bit too early, but I'm starting to see those changes that you were talking about earlier in terms of like the bone density. And for those colleagues in the audience, my colleague Dr. Nika Mernia is going to present at the upcoming session at IADR in San Diego this week. So
very exciting.
If you're there, please check it out, or if this is being you're seeing after the fact, go back to the IADR website, which is the International Association of Dental Research. And I think, that also talks value in terms of like how the research community sees potential in this type of novel biomaterials, and they want to accept presentations that are promoting that.
On the vertical sinus lifts, are you seeing also that change from radiolucent to radio opaque?
It's beautiful. It's absolutely gorgeous. And, I love the fact that with a regular, like, external sinus, when you have to do, like, an immediate implant with sinus lift. Sometimes you go for external or internal, right? Oftentimes when you're doing external sinus lift, you end up like overgrafting. And I think that's pretty common, right? And if you overgraft, sometimes that can compromise the vascularity of your implant and, the chances of that implant being accepted. When you're doing the internal sinus lift, sometimes, you're trying to look at that kind of like little hat that is there. But oftentimes the same thing, you overgraft. So I'm able to see like that little color, not more than 2 millimeters.
Right.
Which I love it. That's exactly what we need.
Yeah.
I think goes back to, why do I believe that, we have a responsibility to advance the field? Because I feel like we need to be able to provide treatments to our patients that are less invasive. So when you think about, 3 vials of the bone graft compared to like half of the little plug there, it's kind of like night and day.
Yeah, I agree. And the amount of healing time necessary, right? There's no comparison when you're talking, like you said, 3 cc's of some particulate in there versus literally a small dome of material that's going to turn over quicker. And for me, I mean, it's important because I want to get these patients rehabilitated in a timely manner. And I think that's important to be able to have something that can accomplish that. And like you said, we're moving into a phase in dentistry which is much less invasive or trying to be less invasive with everything that we do, from restorative to surgical intervention.
Sure. I mean, I think depends who you're talking to, because I think we also have a lot of all on X and all on, which is a completely
that's a different conversation.
But I just want to make sure like people know that they're familiar with that. So I feel like it's almost like we have 2 categories of clinicians: the ones that are trying to be as minimally invasive as possible, kind of like aligned to our conversation, or let's extract all the teeth in a day and all of that. So, but when we're thinking about, we talked about some of the therapeutic indications, and I talked about simultaneous placement of the implant with internal sinus lift. I know you really like doing immediate implant placement, which is not my favorite. We talked about that already, but we agree to disagree. It's totally fine. I respect your opinion. But I know that there are a lot of clinicians that want to do that. So what would you advise them? Like, what has worked well for you?
You can never forget the basic tenets of immediate placement. Number 1, primary stability. And it's difficult. That's the most difficult thing. I'm going to say that's the second most difficult thing. The first most difficult thing is fighting anatomy, right? Where the implant needs to be with respect to where the root anatomy was. And we know that, especially maxillary anterior teeth are built with angled abutments on them already, right? So I think it's, for me, when I look at immediate placement, I truly believe immediate placement, you need to have a cone beam of the site. That's going to give you the value of safety to know what direction you need to go. Many times you're having to go through a wall. Most of the time, like I said, using the example of a maxillary anterior, you're going through the palatal wall of the socket in order to try to gain contact with bone in order to do it. My goal is to have at least 3 to 4 millimeters, hopefully, of the implant in contact, hopefully the tip. Many times, though, we're stuck with only a couple millimeters at the apex of the implant, and then we're using the walls. But with regard to doing that type of treatment and using osteogen strips or plugs as your grafting material, it really is, from a surgical point of view, no different than any other material that you're going to use to graft. The reason I choose to use osteogen products in order to graft that is for a number of reasons. One, with particulate, many times, especially when you don't have a lot of space around the implant, you're packing the particulate up against the wall, and then you're trying to drive that implant in. And many times you're driving that implant in, and if you don't go in straight, you're grabbing a bunch of that particulate. You can drive it ahead of the apex of the implant. And in certain situations, it can prevent you from being able to put your implant in completely, right? Yeah. With osteogen strips or plugs, what I do is I take those strips, I create my osteotomy, and then what I'll do is I'll take the strips and I'll moisten them either with sterile saline or with patient's blood. And we're not spinning blood. All we're doing is we're using a monoject to remove blood from the socket, rehydrating them, putting the strips against whichever walls I feel are going to have the gap. So usually it's going to be facial and
Buccal
maybe,
is usually,
yeah, it's usually buccal. And then we can drive that implant in. And what happens is the implant, as it drives in, is three-dimensionally displacing that graft into the anatomy. And then the excess material is actually being driven upward by as the thread is going down, right? It's bringing it up.
Because it's very soft.
Right, and it's soft, and it's never going to hold you out. Then once the implant is fully seated, then I can put, if it's a healing abutment or a flat cover screw or whatever it is, and I just take that extra material and push it right down on top of the platform. And what I've found is that it's very predictable. It does a very good job. You're never in immediate placement. You're never relying on your graft material for primary stability. It's always the host bone that you can get a hold of. So I think never forget those things, obviously, and know your surgical tenets of what you need to do with immediate placement. Platform is going to need to be subcrestal to accommodate any crestal changes. You need to get good primary stability. If you can do those things, and always place the implant where it's going to be in the proper position for your prosthetics. That is key. I mean, I was taught very early on in my career that, as most people are, implant surgery is a restoratively driven surgical procedure, and you don't decrease the gap just to be able to not have to graft, because then your position is going to be wrong, and the longevity of an implant really is dependent upon position.
Super. So you talked a little bit about the difference between, the plug and other bone grafts. So, we have so many products on the market. So when you evaluate that product, right, what questions do you ask yourself?
Excuse me. So, when I'm looking at a graft material, number one, I want handling. What is my experience going to be? And so that is in one category. The other categories I'm looking at are going to be the ease of use, the turnover time, and then ultimately the quality of bone that I'm going to receive from that material. Looking at these things individually, the handling is extremely important, right? I want a material that I'm going to be able to place where I need it to be and not have it migrate out, not have to worry about it falling into the patient's mouth or having any problems with that, or grafting and then having it migrate later when I think things are closed. As far as the ability to grow bone, that's that's very, very high on the list, right? I want something that is going to grow bone within a reasonable period of time. And as we know, there are a lot of materials out there, and especially in the alloplastic world, there are a lot of materials out there, and many times those materials, and I've been burned in the past, where they break down too quickly. And they break down too quickly, and now bone does not replace. We end up with soft tissue, and that becomes a problem. So I'm looking at the combination of those things. And then, if I can do something that is going to create better bone, then I will do it. And then I'm looking at what else do I need to do in order to use this product. So one of the reasons why, for me, like I said, with socket preservation or alveolar ridge preservation, the plug is an ideal situation. It's also ideal from an economic point of view. And it's an economic point of view because I can get patients to buy into treatment at a lower price point, and then be able to move forward with the definitive treatment that they really want. When you start looking at, and I know that there are a lot of doctors that will say, well, alveolar ridge preservation, you need to place your graft material, and then you need to place either a resorbable or a non-resorbable membrane, and then suture it. Your cost of treatment starts to go way up. Yeah. And especially on the GP side, where we are, most of these procedures are not insurance covered for us. Therefore, our cost is almost 100% given over to the patient, right? And what I want to do is I want this patient to make a decision about what is best for them, not necessarily the decision based on what they can afford. And that's a fine line that we walk every day, and I struggle with that, at times, because I know that I understand from being a dental professional, I understand what should be done. Getting that across to a patient sometimes is very difficult when they're in a financial situation that doesn't allow them to do that. So I try to make that work as best I can.
Especially because you're the same provider that is also going to do the restoration, right? So you're doing the grafting, you're placing the implant, so you don't kind of like give them a break. I feel like for me it's a little bit different because it's like my cost stops here, and then you're going to have the cost somewhere else. But I feel like they look at you as like, you're so expensive. It's all of this, right?
Sure, and it's hard, and it's hard to justify. It's that old adage of when you place an implant, it takes you 15 minutes, and the patient says, "Well, why was it so expensive?" And it's like, well, you're not paying for the implant, you're paying for my expertise, right? And
my practice manager will say, if you want her to take 2 hours to do an extraction, we can do that.
Right.
But
No, I used to say that all the time. I'd say, I can spend much longer in there if you want, or I'll just move the ratchet wrench back and forth until it makes noise for another 5 minutes, and you'll think I've done something. It's a fine line, and it's tough. It's tough to do, but I think that ultimately the best treatment is what we need to lay out to the patient. The patient has to ultimately make the decision on what they want to do. So, Osteogen has been around for quite a while in various forms. Initially as just a crystal form, and then has been developed into the Osteogen product line that we currently see today. Does longevity matter? That something's been in the market for a while. Does that matter when you look at a regenerative material?
I think for sure it matters. I personally didn't know about it since recently, since they started the collaboration with the McGuire Institute. I've heard about plugs here and there, but I didn't know much about it. So I feel like the fact that it has been around for 40 years and, there are clinicians that have been faithful to this technology, that's great. I just didn't know. But I think that's a good sign that, it works. Especially since, I don't think that there was a lot of marketing in terms of or a lot of studies that will look at this with a long term. So I think the fact that it has been around for 40 years, it's a testament that there is some value there.
Yeah.
I'm very excited now to be part of the McGuire Institute, and I'm very honored to serve as the principal investigator of a study that actually will look at some of the outcomes. And, we really try to kind of turn around this material as many phases as we can, from cone beam CT evaluation to intraoral scan to histology. Really, we're patient-reported outcomes, clinician-reported outcomes. We have so many outcomes for this study. It's okay. It's been around for 40 years. Maybe we don't have a lot of data, but I think we're excited to bring some more.
Yeah, I can't wait. I can't wait to see. It's I've been following it kind of from the outside, and I get little tidbits here and there about I know from just my own experience, right, and the experience of many practitioners out there that have used these products for years. Like I said, I started using this product almost 13 years ago in the plug form, and there are still doctors today, as you said, that don't really know of it, and it's really nice to have some sound scientific validation. And there has been clinical work done on all these products through the years, as you stated. But I think things have a tendency to get lost in the literature sometimes. And unless a company has really promoted something, it kind of becomes the secondary thing. It's not the flavor of the day. It should be very good.
And for those colleagues that are in the audience, maybe if we have any periodontists that are joining the American Academy of Periodontology Corporate Forum, I think it would be great for them to join us.
Open their eyes to bioactive crystal technology.
Excellent. As we kind of try to wrap up, going back to the patients, right, which I'm very passionate about. When the patient just comes in and wants to have the tooth extracted, or they need to have the tooth extracted, right? And you have to explain to them, why is it really that matters to do a socket preservation? Like, why is it important?
No, I mean, I think it's good. And patient education is key. I like to not only explain, I draw a lot of pictures. My staff makes fun of me because it's like I'm making cartoons. But what I try to do is I try to get the patient to understand that when we take this tooth out, if nothing is done, here's the potential issues that could occur, right? And I explain to them, it can affect the adjacent teeth. It can cause periodontal problems that you don't currently have and then will arise from it. Sensitivity to adjacent teeth due to recession. And then that the loss of bone. And I explained to them that once you lose bone, you can't grow it back, no matter what you do. And it's going to require potentially another procedure in order to do that. And it's almost a pay me now or pay me later. You can do something now that is a minimal cost to preserve the bone in that area and what you have. Or you can not do something, and potentially down the line, if you want to have an implant placed, you're going to have to undergo another surgery, much more extensive, much longer treatment time, and much more costly. Yeah. And so that's how I kind of present it to them and get them to understand why we're talking about this. And ultimately they can make that decision. But what I've found is that the majority of patients that you explain it to them, and I think the loss of bone is really a major thing. I think it was a Clark study many years ago that they went back retrospectively and talked to patients, and over 60% of the patients said they would have done grafting if they would have known that they were going to lose bone. Yeah. And that is something that I've always kind of touched upon, that it's the term or the one small thing I can talk about that's going to resonate with a patient, and they're going to go, oh yeah, you know what, it's a good idea, even though it's not covered by my insurance. It's a good idea to do this. And it gives them, I tell them, it gives you a window of opportunity. It gives you options later on. Where if you don't do something and things don't heal the way that we want it to, you don't have the same amount of options
later on.
Yeah.
And if you had colleagues that, for example, they used osteogen plug, they tried it, but they never follow up on that healing, what would you tell them?
Well, I mean, that they didn't get a good outcome, or the outcome that they wanted?
They just tried it once, and they just didn't follow up. Like, I don't know exactly what happened, but most probably you would ask them what happened, right?
Yeah, I think, first thing I do is I always would ask, how did you address the case? What did you do? Did you clean the site out really well? Did you get, good bleeding in that area and a good blood supply? Especially if somebody says, well, I tried it and I didn't quite get the results that I wanted. Right. And so I'll say, well, let's talk about what you did. And more often than not, when I have that conversation with somebody, they go, oh, I didn't know I was supposed to do that. Right. It's nobody likes reading instructions, right? I'm a perfect example. I'll get an IKEA table and I'll try to do it without looking at the instructions, right? It's a challenge for me. It's like a puzzle. And most of the time I fail because I end up with extra pieces that I don't know where they're supposed to go. But I think that there are clinicians most of the time that try a product and maybe they just don't get the result, or they don't feel they got the result that they wanted that one time, and then they never look at that they could have been the fault of it. It's always the product, right? Always. I did this composite, it failed. Oh, it's crummy composite, or it's a bad adhesive. Yeah. So that's why I always try to take a step back, and I do this a lot where I will talk with doctors who'll say, oh, I tried the plug a long time ago, didn't really work for me. Okay, well, what did you do? oh, I did this, this, and this, and this. Well, if you didn't do this, it's not going to work. That's the one thing with the OsteoGen plug and that family. You really need to follow the instructions for how to prepare the site. Because, and that goes with anything, right? Because, I mean, if you do grafting with particulate, you don't follow all the tenets. You go and you do a ridge augmentation, but you don't decorticate. What's going to happen? You're not going to get any bone.
I mean, depends. The studies say that there is a difference, but depends on the author.
So
but I get what you mean, like kind of like a step by step.
If you follow what is prescribed to get success, then it'll happen. And so I usually tell them, take another look at it. I also ask them, what product did you use? Was it really an OsteoGen plug, or was it some other thing that looked like a plug, right? Because historically there's been products out there that are just collagen, which are not graft. And nowadays we have a whole product category of calcium carbonate plugs, which are functionally very different. They look the same, but they don't act the same. So I always ask, where did you get it? Who'd you buy it from? Are you sure it was OsteoGen? And maybe it was. And if it was, then we talk about it. If it wasn't, then that's an easy conversation to have, because then I know what the problems that could have occurred with it. I think having the conversation with them to see if they've actually followed instructions or not. So with regard to using OsteoGen, what does that product do for your patients that would be harder or not even possible if you used something else or you weren't able to use it?
I think for me, it really goes back to who is my patient, right? And I think we talked about it. I like to have that conversation with the patients. Do you have any preference in terms of the origin of the material versus human, versus animal, versus synthetic? So I think kind of like goes back to that. I think, so it's able to support some of those patients that, they just have one preference versus the other. Then I think in terms of the communication with the patient, I also feel like because of those positive radiographic changes, I can show them really well. It's like, this is how it looked then, this is kind of like how it looks now. So it kind of like really helps me with that. And then also in terms of the cost, I think it's very economic. So I think especially for my patients at the school, works out great. But, I think for every patient. So I think that if they don't need, and I always tell them, I consider myself pretty conservative. If I don't need to do something, I'm just not going to do it. Yeah. So I think, it offers a lot of variety, but again, my favorite therapeutic indication by far is internal sinus lift. Okay. I think that's a niche that there's no other material on the market. I think extraction reach preservation, GTR, we can achieve that, but I think it's able to prevent complications like Schneiderian membrane perforation, which we know 40% of our sinus lifts have this type of complication. Yeah. So just preventing that complication, from the sinus, it gets much more complicated. So I really love that aspect.
Nice.
So when you think about a case, Chuck, and just walk me through one of, from your almost 15 years of experience, walk me through a case that really kind of like, as you think about that case that really, in a way, confirm that this is my choice of material. What will that be?
Oh, wow.
I'm sure you have a few.
So. Yeah, no, there are. And we do
have to go home at some point.
I think that stands out. I think one of the issues that definitely where you can have a bad outcome is when extracting a posterior maxillary tooth, right? Okay. So I can think of a case where we had I believe it was tooth number 2, and we already had on the radiograph, you can already see the sinus is pneumatized over the top of the roots, and that if you take that tooth out and not do anything at all, there's nothing's left, right? You'll end up with an eggshell thickness of a crest. And I can see the radiograph now on that, and we got the tooth out and we grafted it with an OsteoGen plug. And Didn't do any vertical, in retrospect, that probably would have popped the apex up a little bit, but we didn't do anything at all. And then we sutured it, brought the patient back at 2.5 weeks to take the sutures out, and literally the soft tissue was just about closed over the top of it. Which this was a very early case on when I started using this product. And I was amazed because it was very different from what I saw using other techniques, especially using a PTFE membrane, for example, where the soft tissue never will close over the top of it, and that's why you're going to be pulling it. And then bringing that patient back at about 4 months, I think we saw on the follow-up, and taking a radiograph and seeing that all of the bony architecture that was there being held up by the roots was still there, and now had converted from this radiolucent hole to bone that had, trabecula and everything. And we were able to, it made me feel so good that I said, we can go back and we can place an implant in this area.
Super.
We could never have done that unless we grafted it. So it really like stood out and made an impression on me that I was like, wow, if it can do this in a very difficult area, because obviously we know the posterior maxillary arch is probably the toughest area to get good results, because we've got a lot of pressure stuff going on. It stuck with me. So it was one of those ones that I draw back on very often when I think about this. So have you ever had a patient? I know we talked about sometimes things don't work out. Yeah. Somebody else does it, whether it be a GP or another specialist, or maybe it was done a long time ago. We don't know. And they were grafted with a different product, and the outcome wasn't exactly what anybody hoped for. Have you ever then treated one of those cases and used osteogen as part of your revision surgery for that?
I don't remember of any failed, deep kind of dry socket, but I do remember of peri-implantitis case that was pretty severe. And, it was at the point that, we were planning to remove the implant. So I was planning to kind of open it up and just kind of remove the implant, degranulate, and then place the plug. So, kind of I opened my incision, try to, and I see the implant doesn't have any mobility. So, and this is also a patient that he has been my patient since I was a perio resident. Yeah. So
did you place the implant?
I did not.
Okay.
I did not, because he was a patient at the school. So, he had kind of an implant base here, an implant base there.
From all different decades,
exactly,
right?
So he gives them a name to all of them, right? But, I'm the only one that kind of stayed in the area. So I think he got to a point that at the beginning, he was working, so finances were a concern. So he was at the school. By the moment I graduated, he retired, and he kind of followed me when I was an associate, and then to my private practice. So I told him, okay, Mr. D, I'm going to try to open it up, see what's happening with the implant. Then I look at the implant, has good stability. So I'm I'm just going to try to clean it out as much as I can. And then we'll see what happens. I mean, you know me well enough. If it's going to fail, you just come back, I'll remove it, and then we graft. But it has been great. And I see those positive radiographic changes, and now the implant has a crown. And I feel it was really a case of a hope for a hopeless implant.
Sure.
So, which was amazing. So, and I don't have, when we think about other potential, I have other situations where I used it in different therapeutic indication, but I would say that was the most kind of dramatic case in a way that, to be able to, I cannot say that we regenerated the bone around that implant, because, that's going to be very difficult, but I can just tell you that that implant is pretty stable. You can see positive radiographic changes. And while around teeth, I feel pretty comfortable with that regeneration and with that PDL. Around implants, we're still trying to identify what is the best protocol to manage that peri-implant disease.
Yeah.
So I feel the fact that this has been successful, I'm pretty hopeful that, there is much more to explore and discover in terms of the potential of oral regeneration when we're considering the osteogen plug.
Fantastic. Well, I want to thank you very much for
My
taking the
pleasure.
time to talk. I always enjoy talking with you, and
Same.
this was really great. I'm sure we could go on for forever, and but then there'd be nobody else left to watch what was going on. So I thank you again.
Thank you.
I think the next time I'll probably see you will be at AAP,
Yes,
and I'm looking forward to it.
the same.
Absolutely.
Thank you so much
All
for
right.
having me.
Thank you.